So yeah, thank you guys so much for having us and devoting some time out of your busy schedules. I'm Cailin Conner. I'm a assistant professor in the department, and I am presenting with Maddie, who works at CAD. My apologies to the couple folks that met us in Erie. This talk is pretty similar. We added some more information though, and some specific questions from your group, at least from STAR. So, and I also wanted to shout out Bahia Antazana, who also provided some slides, and Jacob Feldman, who presented with us in Erie, who also provided some slides. He's a grad student at Pitt. So I work through the React lab here in the Department of Psychiatry, and Maddie is at CAD, adult mostly, but some child as well, which she works in the outpatient area. I also do some adult assessments. And I will say, based on my experience on postdoc here, I used to switch between doing adolescent and adult assessments, that referrals from you guys, and even just like people who had attended programs before, usually were pretty positive about your programming. So I'm excited to work with you guys and at least give you some information. Not really any disclosures. I always just put this slide up. Our React Lab currently has a large like P50 grant, an Autism Center of Excellence that is focused on mental health and suicidality and autistic adults. And mostly Dr. Iannotti. Any good looking graphic that I have is mostly Dr. Iannotti, who is an amazing artist, among other things. I always put this on every talk that I do that is about suicide. You guys already know this, you're experts, so I'm going to skip. But you know, always take care of yourselves first when you're talking about this stuff. We can always connect later. The learning objectives that we had in our Erie talk, we're talking about identified the increased risk and protective factors for suicidal thoughts, behaviors, and self-harm. We talked about adapting assessment, and we added in a little bit specific to the assessments that are used at STAR to give some feedback. And then we also talked about conducting safety planning and ongoing treatment. So we also beefed that section up a little bit, talking about UPMC's safety plan in particular, and specifically, you know, some more information about treatment and groups and different modalities of therapy. And now my computer doesn't want to advance. Cool. There we go. So in terms of language, you probably already noticed that I've said autistic people rather than person with autism. I know traditionally, like most of us have been taught to use person first language when we're talking about, or you know, any sort of mental health condition. So you know, you usually say person with depression, person with schizophrenia, but this is changing specifically in autism. And a good amount of people prefer person or identity first, so saying autistic person. I will say that that is not like standard across everyone, so I always just ask someone that I'm working with, especially if I'm going to be talking about how they relate to their diagnosis. I always just ask them. On the spectrum is also okay too. Like I feel like that sometimes is like a good medium ground, but I think especially when you're working with younger folks, it seems to me, and some initial information from a paper that I'm working on seems to suggest that the younger somebody is, the more likely that they like autistic versus person with. But again, not standard across people. You guys know autism diagnostic criteria at this point. You know, I don't need to really cover it. I'm going to skip through. The one thing I would say that's important is like, while most people think of autism as, you know, this line that you're seeing on the left side of the screen, like, you know, when we talk about levels or it's in the DSM-5, we usually, I think of it more on the right, and I kind of really like this kind of conceptualization or something like this, where, everybody really differs in all of the different characteristics and related mental health characteristics. And so the old saying in autism is when you've met one person with autism, you've met one person with autism, because everyone is so different and it's such a heterogeneous group. So, I think what's important to think about, especially, given that DSM-5 has that one, everybody is diagnosed as autism spectrum disorder. There's a lot of difference within that of what people are actually going to look like and how they present. So really quickly to talk about autism and mental health, this stuff might be things that you guys are familiar with because I know both groups, both CAD and STAR, have a lot of, autistic folks in them that are getting services. We know that, mental health is pretty common. So generally speaking, the most recent CDC assessment in the US says, we've got 1 in 36 children diagnosed with autism in the US. And the most recent estimate, again, I don't think it's like, we're never going to get a full count, is about 2% of American adults. So when you think about how since the 90s and going through DSM-5, like we have broadened what our conceptualization is of autism. It is no longer something that is rare and what we usually think of as like higher support needs. There's a lot of people that are included. So there's a lot of folks, and a lot of them are adolescents and adults. And then in terms of mental health, generally, most of the assessment is like majority of people have a co-occurring mental health condition at some point in their lives. ADHD that we now can co-diagnose with autism is pretty frequent. Most of the research has been done on anxiety and depression and OCD, and we know that those are higher rates. There's more research going on now, but still pretty little on PTSD and eating disorders and a lot of other conditions. We're assuming that they're higher, or at least at the same rate as the general population, put it that way. So what I usually say to anybody working at Western Psych in any field is like, you're going to run into autistic folks. As part of the REACT lab, we focus a lot on emotion regulation, kind of as, that trans-diagnostic process. So mental health problems, difficulties managing those emotions are really common in autistic people. And there's a lot of reasons why, we might see a lot of co-occurring mental health issues. Traditionally, we kind of think of these ones, again, towards the left. There's genetic and neurological differences probably for why that's so. We know genetically it's tied. Autism seems to run in families where there's also mental health issues. And the diagnostic criteria for autism in themselves can also create, maybe in some cases, mental health issues. So, thinking about like really preference for sameness or sensory overwhelm and difficulties with the world that we live in. A lot of autistic people also have difficulty recognizing and understanding emotions, which we'll talk about, and difficulty communicating about their own emotions, which I'm sure you guys see. So all of those things. And then more and more as our field keeps progressing in this area of looking at mental health and autism, like we're seeing more about these last two on the right. So thinking about the fact that autistic people are living in a world that is not designed for them, where their disabilities are often not accommodated. And, we know that those things are going to create an issue, and quite possibly create some mental health struggles and stressors. Hey, I didn't know I had done this way. Sorry about that. Sometimes I get ahead of myself with the animations. So kind of feeding off of that idea, right? Like we know that there are other things that are in the last few years we're seeing in research, like a tie between, masking or camouflaging your autistic traits to fit in is linked to higher levels of anxiety and depression symptoms, for instance, or, like difficulty with managing emotion dysregulation or those sensory sensitivities or needs. And also knowing that, autistic people experience more discrimination and trauma when we think about this as a disability group, there's a lot of things that are feeding into some poor mental health as well. Okay, very quick overview, which I can totally answer questions later. But I'm going to skip into that kind of first aim today and talk about autism and suicide more specific. So I think, this is from a colleague's K Award out in Utah. And, I just thought this quote was really an important one to think about of why this is so important. And this participant, an autistic adult, said, this is the rule rather than the exception. If somebody isn't suicidal, it might be just because they're pushing it out of their mind because of the feelings of rejection and the rejection that they experience. I wanted to show a quick video, if I can get it to work, from some of our partners and in the React Lab about autism and suicide. See if I can get the sound to work.
I think autistic individuals,
can you guys hear
because we are so much more overstimulated by the world in so many different fashions, the likelihood that an autistic individual is going to be suicidal during the course of their life is probably much more likely.
I've been thinking about this a lot recently because I've been experiencing a lot of grief and I guess kind of processing trauma over the fact that my life doesn't look like I thought it would. And to me, that is also very closely tied to the fact that the things I'm seeing some of my peers doing are things that no longer feel like they're part of my life, or no longer feel like they're going to be part of my trajectory or whatever.
I think how much some people don't have a lot of resources or a lot of supports around them, and that's a big factor in why I think that could be a big factor in why people with autism are committing suicide.
Staying alive shouldn't be revolutionary. I don't know, and that's how things feel sometimes.
Okay. I really just love some of their points. Whoops, so let's see if I can skip past it now. There we go. Okay. So basically all of the research in autism and suicide, or the vast majority, I should say, has basically been in the last 10 years. So this is still really a growing area. And part of, the reason that I got interested in it myself as someone that looks at mental health. We know that this is probably a leading, cause of premature death for autistic people, other than, other medical issues potentially. We know that autistic people are more likely to die from suicide. Recent meta-analysis, that pulled kind of the prevalence rate, thought about, basically that we're talking 1 in 5 for suicide attempt across a lifetime, and about half, if not more, of autistic people having suicidal ideation at some point. Most of this research, though, I'd say, we have studies that have looked at, population health records, and we've got research that is more convenience-based, online samples. So we're talking more adults, more lower support needs, folks that are more highly educated, and a lot of folks that were diagnosed as adults. So there's a lot of things that we should think about with caution with this, number, but there's still a lot that we have to figure out. There's less that we know about autism and intellectual disability because of that, but the research that is out there, the few studies show an increased risk. And child and adolescents, I'll talk about on the next slide, because I knew that would be of special importance here. So when I looked at this stuff, it's all been studies in the last couple of years. We're seeing some concerning stuff with autistic children and teens, which I'm sure you guys have already, This large online study that was done using an autism research registry found about 40% of folks reporting suicidal thoughts. about 1 in 5 reporting to end their own lives, wanting to. And many of these had reporting an onset when they were 8 or younger, so really, really young. And then a preprint from a colleague of mine in California. Whoops, go back. Then she was combining her data with some Canadian and Australian colleagues. They had looked at seen the youngest age of attempt in their sample was 7. And the average age of attempts for youth was about 12 years old. And then for adults, the average age of attempts within that sample was about 19. So definitely within kind of your guys' ranges. So this is something that we do need to really think about, especially when we're working with kids. So in terms of risk factors, like I said, all this is from the last 10 years. I'd say like most of the research so far has been on, prevalence rates and risk factors. So I can go through a little bit, but there's still a lot that we don't know. So things that you guys see in the general population are pretty much similar. In a lot of ways, we see, co-occurring mental health conditions, up in risk factors, lack of social rapport or social isolation, or like one of our partners mentioned in that video, not having your needs met, basically your support needs. A history of trauma or victimization, all of these things that you guys see, as risk factors within non-autistic folks are similar. We do also have to think about how people have other identities. And so, autistic people are more likely to identify as LGBTQ, for example. And obviously, there are also autistic people who are other minoritized groups. So those are also identities that we don't really know how they're interacting, but we could assume if the other identity group has a higher risk, so would an autistic person with that identity. There are some initial studies on like what's different for autistic folks in terms of risk factors. Camouflaging or masking, I think I had already mentioned, is kind of like suppressing or trying to act not autistic to not stick out. We do see links to mental health outcomes, like I had mentioned, but also it seems to have come up in some studies looking at risk factors. Perhaps, spending more time trying to not act like yourself or suppress certain things might be linked to, more mental health struggles and then also suicide risk, at least for ideation. Autistic burnout, which is basically like other types of burnout, but linked to kind of just like an overall sense of exhaustion. And sometimes we even see a loss or regression of skills. We're seeing that tied to suicide risk. It comes up in some qualitative work. Gender differences, we're kind of have mixed findings. We don't really know yet, if there's the same differences there that we see in other folks. And something else that's a little bit different than non-autistic populations is that getting diagnosed as an adult. So someone that is undiagnosed as a child, but gets diagnosis later, we see some increased risk for suicidal thoughts and behaviors. There's really little on protective factors, which is something in our group we're really interested in trying to understand too. Some ideas, I think, for protective factors, having a sense of social support and connectedness, which might look a little bit different in an autistic person compared to someone who isn't, but something like that, having the sense that you have people that can support you and that you can rely on, and just like overall sense of well-being and quality of life, I think, is important too. So talking a little bit about that self-injury piece, self-injury is relatively common in autistic people, but it's a little bit complicated and how we talk about it, just because of the history. So in most autism research to date, we've talked about self-injury as self-injurious behaviors. So this kind of right side of the Venn diagram. And so, it's been focused on with folks that are typically higher support needs. Typically, it's been thought of, intellectual and developmental disabilities as something that is, a repetitive behavior coming from sensory, usually has some other kind of like behavioral motivation that people tried to think about. Whereas, for the research that we've done basically in the last 10 years on suicidal self-injury, like that research base that Starr at least is very familiar with, I'm sure, is, thinking about self-injury as having kind of an emotion-based regulation kind of reason, or potentially socially motivated. So like I mentioned, we have this long history of studying this in autism with self-injury, but that research base really looked at this linked to lower IQ and different forms of self-injury than potentially you see in NSSI. There's research suggesting, though, that non-suicidal self-injury is more common in autistic people as well. This research has almost all been done in people that don't have intellectual disability as well. And it seems to be higher than the general population. Also has some different forms, potentially, than NSSI and non-autistic populations. Okay, so I'm going to talk about assessment next, if that's okay. This section, Jacob had mostly put together, and I think it's interesting to just give a little bit of background. So he is a graduate student who's not an autism-focused clinician or researcher, and he pulled some quotes from our ongoing study, which is with adults 18 to 65. So he pulled up some things that are common, he felt, and coming up when you're doing interviews. We mostly use the Columbia, the CSSRS, and some sections of the CITB in our interviews. So for him, he said, the first thing that came to mind for him was long questions. And I feel like the CSSRS has this a lot. So, these kind of questions that have lots of commas and lots of different pieces. We've found that a lot of times it can be difficult. And a lot of times we have to repeat ourselves and go back and kind of take one section at a time with folks for them to really understand and be able to answer. So his example, in the past month, have you had thoughts of death, any intent or harm to kill yourself, or made any attempts to take your own life? It's sometimes easier to start with the shorter first part and kind of follow up piece by piece. Another way that we found that can be helpful is to put any information that we're trying to give in multiple ways. So having visuals while we're reading things out loud, or having the ability for the participant to read the questions themselves sometimes can be really helpful. So an example is for when we're talking about the Columbia, like in the beginning, we say, and have this on the table, we talk about this in terms of like levels. So we're going to talk first about this, bottom part of the thermometer. We're going to talk about kind of like suicidal thoughts and more passive thoughts to suicidal ideation. And then we're going to talk about, methods, and, we keep moving our way up. So we kind of say, like, here's how we're going to progress and give people an idea of what it's going to look like. And that can be really helpful. Another thing that we've found a lot is that most of the time, well, not most of the time, but it does come up pretty frequently, like someone's definition of what ideation or a plan is different than what we think. So, or what we're getting at, and how it's defined, in the CSSRS. So we try to kind of adjust our language to the participant. And you might have to talk to them about what their definition means and say, that's okay, but like what I'm asking about is this, so that we can really understand. So an example from our notes was, have you ever felt down, low, down, sad, empty, or hopeless for mental health interviews? And the participant said, no, I've only ever been melancholy. So then we had to follow up and say, what does melancholy look like? What's it like when you're melancholy? And then understanding that their answer was, I had trouble sleeping, I lost my appetite, and I was always tired. Well, okay, that is what we're looking at for depression. So that we kept going with the depression interview then. Another thing is the directness that you kind of need to use in your language. And I know, folks that are skilled at asking these questions, especially with youth, are good at being direct. And so that's just a skill that is especially important no matter what the age. For somebody that's autistic, you really do need to say like exactly what you're trying to ask. So an example here was, asking about passive thoughts of suicide in the last 6 months. Can you push these thoughts out of your mind? The participant didn't really understand, like, what do you mean? And they said, the interviewer came back with, well, what was going through your head when these thoughts of death came to you? And the participant said, well, these thoughts would come and go and I'd move on. So I never tried to control them. So that question in the Columbia about like controllability of those thoughts wasn't necessarily the most relevant because the person didn't really try to control, so that option for that we have in our version anyways is, didn't try to control the thoughts. So sometimes you're just going to have to probe a little bit or redefine a question and reword it. So, another way that Jacob kind of put this, which I think is really helpful, is our usual follow-ups of like, tell me more about that, doesn't always help as much. So sometimes you're going to have to like take the piece that you want to know about. So tell me about those thoughts of falling asleep and not waking up, really using their words and kind of turning that back to the question so that you can get more information. It also helps, I think, for an autistic person to kind of keep them remembering what they just said. Another thing that we notice in our interviews and assessments so far, and working with some community mental health providers too, is it seems like chronic suicidality is quite common. In autistic people, I don't have literature on this yet, but I think it would be fair to say. So it's been really interesting to talk to some folks and know that, they feel like that's something that's pretty consistent in their lives, and they just learn how to manage with support. Something that we've also noticed is a different relationship then with suicide and suicidal thoughts. So we've had folks talk about how it's comforting for them to know that they have suicide as an option. And we've had folks who, think about it pretty frequently and it comes up a lot. And it sometimes can feed into kind of like an intense interest too in like life and how people's bodies work and the science of that and all these other things. So sometimes you get these different answers that are quite different and interesting and can be, alarming, but you kind of have to probe a little bit. And we'll talk about that. There's differences, I think, when we've asked about non-suicidal self-injury for sure. So we've had quite a few number of supervision discussions about how we parse apart NSSI from like sensory and emotion regulation, dysregulation issues. So it's been quite interesting. I'll get into some of this. So we found that there are some autistic folks who have a behavior that they find soothing, but can be adjacent to self-harm. And we found for some folks that self-soothing behavior, like deep pressure or something like that, can get to a point that it could be, can increase in a situation and then become more like self-harm. So we really have had to think on the fly a lot when we're talking to people about this, of like how we parse these things apart. And kind of going along with that vein, we've had several autistic participants that felt that there was a difference between pain versus harm. So to them, pain sometimes was a way to reset their regulation. And so, maybe repetitive behavior or self-soothing behavior that they engaged in does cause pain. So when we ask those questions, like, are you doing anything to cause yourself pain? It doesn't go well. If we go with, does it cause harm to you? Which I feel like these words sometimes are very similar, but they had a differentiation that we kind of had to talk through with them to understand, like, they feel like, something that causes very minor pain or very temporary can be really helpful to like I said, to like reset their self-regulation. Whereas, something that causes them harm is different. Definitely more that we need to figure out on this area. So one example from a participant was, I pick at my skin to help me regulate. Sometimes it leads to bleeding and scars. When stimulated, I'll pick at the wounds too, and they reopen. It's not about the pain though. The pain's secondary. The pain helps ground me though and release my emotions, but I'm not doing it for the pain. I'm doing it because of the discomfort that having the spot or the unevenness on my skin causes me. And because the pain is useful and distracting me from everything else. So again, it's like some of this is self-regulation. Some of it, in our definitions would be self-harm. Some of it is sensory. It's hard. You always can come to us if you have a lot of questions. When we ask some clarification, a lot of the time we're asking, if you're hitting yourself or hitting a wall, was this during a meltdown, like a period of really strong dysregulation? Or was this when you were more regulated? Were you doing it because you wanted to harm yourself? A lot of times, the question about harming themselves comes back with stuff that happens during a meltdown or dysregulation. And so we don't necessarily count that as, NSSI because it wasn't done with the intent for that. The other thing we found with suicidal or suicide attempts is that folks might have a different view of attempts. They will not count things as attempts that we might, or vice versa. And so while we usually just will continue assessing and ask more details so that we can kind of make that distinguishing decision for ourselves. So an example of this, oh no, I just skipped right ahead. Okay, sorry. So there was a question from some of the clinicians at STAR about confusion about methods. So I'm not sure, it is difficult. I think there's more about methods that folks aren't necessarily going to notice something as a method versus not. I think one of the most important things I would talk about is, in terms of an interest, is whether there is a change from a baseline for that method. So I think an example would be better. So if someone has an intense interest in medieval weaponry or something, if they have a lot of those things in the house, understandably, if someone is going through a tough time and they are coming and presenting to STAR for therapy, you're going to ask about those things. And it might be very difficult to ask them to remove those because they are something that they're really interested in. Now, if it's something that is a long-going interest and predates any mental health struggle, and they've never been used in any sort of plan or self-harm or anything, there is a difference there between that and a new thing that has popped up as an interest or an intense focus and something they're thinking about a lot. So Maddie will have some good examples on this, but I think, it's important to kind of think about those methods in that way. And really, for me, a lot of times is assessing across any mental health is like, what's the change from a baseline? Like, what's somebody's baseline, and has there been a significant change in that focus or mental health symptom? Because to me, it's really important to know, like, is this person, and it might be helpful in this case to talk to caregivers, especially, is like, is there a baseline level of irritability, for example, that has kind of always been low level and present versus, is this a new thing? And then Maria sent us some of the main measures that you guys use to look at. So I can go through those. So the ASQ, the Ask Suicide questionnaire, this screener has been used actually even more than I had thought. I did more of a lit search in autistic youth and young adults. It seems to be working pretty well. So there's a couple studies out using it in inpatient. There's some studies using it in outpatient settings with autistic youth and young adults, and emergency department settings too. I know there's a big study going on looking at safety planning, and they're using this measure. So it's screening in different settings, including emergency departments. So we do have some good evidence for that. So awesome job. You don't have to do anything with that one. I'd say for the mood timeline that I saw, I like the range on this a lot. So, you have this kind of like 5-point scale that you're using. I would suggest potentially if someone's struggling, or if you're asking them questions and they're just looking at you with a blank face, maybe personalizing it a little bit. So a lot of times in therapy, I do this with folks where, what does, the top of your emotion range look like? Like, when are you the most happy or the most anxious? What does that look like? When are you the least? And so you could do that with mood the same way, with the understanding that, of course, maybe they don't have that super high, mania symptom or vice versa. But I think starting from those ends, then going to the middle, like what your typical is, and then doing those kind of like second and fourth ones and defining what those might look like. The other thing with that timeline is, you're reporting over the past ages and grades. It can be really hard for some autistic folks to remember, or to, again, have the ability to talk about their own emotional states, and especially to generalize over a really long period of time like that. You might want to work with a caregiver there too, and talk about like specifics to link it to time to help with the memory piece. What's something big happen in, third grade or fourth grade that you can kind of tie the timeline to. I think that's always really helpful. Oh, I skipped one. That was fun. I skipped my first one. Cool. So I had 3 slides somehow on this, and then it went away. So generally speaking, for the CSSRS, the ideation items seem to work pretty well. We've been using them, and we really haven't changed wording very frequently. One thing that we do use with an interview like the Columbia or the CSSRS is like, we show the response options for each item as we're asking the question and going, we verbally say it, but we have it on a page. So we have them in one per page in a binder in a sheet, or if we're doing it online for follow-ups, we have PowerPoint with each of these on one page, so that the response options that we're asking are there, so that it's a little bit easier for the person. It's just a lot of words, so it can be helpful to have it written out. I think this is helpful for non-autistic participants too, just because, again, it's a lot of words. So the other thing I wanted to talk about was wording. So we have a version of this here at the bottom, but the version I saw kind of in your version of the Columbia, you have a question that you added in about how likely are you to try to kill yourself now within the next week. So there's a paper from a couple years ago in the UK that was looking at a suicide screener and found that autistic people answered this kind of question differently. They were more likely to endorse ever. And this question wasn't in the next week. It was like, ever. Would you ever kill yourself. So you might get more possibly responses here just because of the really literal thinking. So like, I don't know, I can't predict what I'm going to do in the next week. So maybe you might get more of those. So I think it's really important to kind of talk through the person, like their reason and their kind of thought process for responding. So just to be aware of that. An example that we have in our Columbia that we've learned is this last one here in this box. So for suicide attempts, we have like, have you made a suicide attempt? Have you done anything to harm yourself on purpose? Part of you trying to die. The last one here, have you ever done anything dangerous where you could have died? This last question gets taken literally a lot. So we've learned to really think through, like, talk to the person about it, because we'll get a lot of like literal, like, I didn't look when I crossed the street. Well, were you trying to kill yourself? No. So like you kind of really have to think through like the most literal way that you could answer a question, and understand sometimes you might get that from folks. Okay. Oops. There we go. I'm going to let Maddie take over on safety planning and treatment because she has a lot of great experience with this. So off to you, Maddie.
Thanks, Caitlin. And good morning, everyone. So just a warning for this section, as Caitlin has said multiple times, the research on this is very limited and very new. And so there is a lot of research in production for this right now, but not a lot out. So I'm sure if I present this in 5 years or so, it's going to look very different. But for right now, just know we have a limited amount of information. So just starting in a paper that looked at themes in adapting safety plans for autistic people, having the right supporter is really important. So this includes both the therapist. The therapist needs to be a trusted supporter in order to get an accurate safety plan, but also we might rely more heavily on a support person, especially for teens. So a caregiver or a friend or someone they value as a support person for their safety plan. And then having the right time and place. So this can include telehealth versus in person, where they're the most comfortable, in what environment they're the most comfortable in, and then not in the middle of a crisis. So when we're out of 10, we're not going to come up with a really good safety plan. I understand we might have to do a little bit of safety planning at the end to make sure our client is safe, but for our in-depth safety plan, we need to not be in the middle of a crisis. We need advanced preparation. So some things I might bring for my safety planning includes scales, visuals, measures. I will come in generally with a list of things they've said they've enjoyed or have helped them in the past, just so things are ready and right there and they can see examples and things to have, making the process a little bit easier. And then safety plans need to be a flexible process that meet the individual's needs, preferences, and experiences. And these will probably look different than the clinician's expectations. They often do. So for example, we might encourage increasing socialization, but that can make autistic people feel worse, or it could look different. So maybe for them, it might be engaging in an online community, which we wouldn't traditionally encourage as much. And then we need to include participants in the design of the safety plan, making it effective for them in every step of the way. So sometimes this looks like taking multiple breaks, skipping around sections, coming back to sections. Sometimes for some of my clients, this is a multiple day thing of stopping when it gets too much. Sometimes it leads into other stories that are more important at that time. So really being flexible and creative. And with the STAR presentation we saw you all do a great job with creativity with safety plans. So this is a skill that is really great that you all have. And then coming up with some just new and creative things too. I like to have a list of maybe some popular answers people have and just some options of what could be helpful for if people get really stuck. Right, thanks, Caitlin. Some additional considerations, and you're going to hear a lot of these adaptations and things multiple times, such as visual aids, short, concrete instructions, a consideration that sensory overload and social burnout can intensify a crisis. So including these areas into your safety plan for autistic person versus where it wouldn't be a consideration, most likely for other people. Role-playing safety plans, this is something that I have found extremely important, especially when it comes to things that make my clients more anxious to do or they might forget to do, because repetition is really helpful and important with autistic clients. So an area where I've done this a lot is what it would be like to call crisis, specifically resolve. We've role-played calling crisis, what it's going to look like, lots of psychoeducation about crisis is unlikely to call the cops, they're unlikely to send you straight to the hospital. Majority of the time they talk on the phone, just because that's an area most of my clients get stuck in. It's also an area where a lot of my clients use as support. Crisis is used a lot as a support and a very helpful one. So that's something I role play a lot. And then this is an area we've talked about a little bit, but be mindful that certain interests can intensify suicidal thoughts. I have the example of death and weapons here, but I've seen one from like true crime and knowing more unique ways that someone might kill themselves. And so had someone go into like a 10-minute telling me a unique way they might kill themselves, but they had no intention. They didn't have access to means. So it can sound really scary when someone has these interests, but really getting into, do they have the means? Do they have the intention? Have they changed their anything they do about this interest to further these plans? There is an autism adapted safety plan. It was developed by the Mental Health and Autism by the University of Nottingham. It is extremely overwhelming. It is 33 pages, so it's really, really long and not practical to use in sessions. So our recommendation for this safety plan would be to look over it because they have a lot of helpful examples. So I know it's really tiny, but on this specific page, the question is, where are my warning signs that I may start to have strong thoughts, feelings, or urges to hurt myself? And then they have a lot of examples that might be common. So example, reduced enjoyment and a strong interest, a change in routine, change in patterns of sleep, eating, and mood. So if you're someone who's newer to autism or don't work with a lot of autistic clients, it may be helpful to look at some of those examples of what might be common. And then in the back of the plan, they have a lot of visuals that could be helpful for you and a lot of examples that could be helpful for you. And so taking what is helpful from this and then putting it into our UPMC safety plan has been what I've found most successful. And for the next slide is an example of some of the prompts they have in the back that I think are especially helpful for newer therapists. Some common areas where we may not anticipate getting stuck and where we might get stuck and have some wording or help of how we can get through it. And so I'll go through this prompt with an example of something I've done with a client before. So I might say something like, you said that you have experience using razors to harm yourself before. Would there be a way of keeping yourself safer by getting rid of the razors? They said no. Okay, so where do I go from there? And so this prompt helps kind of guide that and some of the other prompts in the back. So no, they were not interested in throwing it away. Is there someone that you trust that you could give it to keep it safe for a while? They also said no. That's okay. We appreciate that this is a hard thing to think about doing. Where do you currently keep the razors? They kept it in their shower caddy, and this made it really more tempting for them to cut because they were doing it in the shower. So it was a very location that wasn't very safe and very convenient for them. And so could we think of a safer place to keep it? Over some time, we decided on putting it in a Ziploc in one of their drawers in their dorm room. So separating a little bit more between when they have that thought and the access they have to means. So that's my recommendation of, if you're getting stuck with some autistic clients, of looking at that safety plan and just taking some of it, but not actually using that safety plan as a safety plan. Some helpful considerations and some of our observations of when we've talked as colleagues that we've noticed. When feeling stuck, focusing on increasing protective factors and decreasing risk factors. This is always something I remind myself when I feel stuck or overwhelmed with something a client might be telling me, or not sure where to go here. They keep saying no, they're not willing to do that. Impulsivity and reactivity are really important to consider in the autistic population. And that's where we see a lot of these thoughts coming from and a lot of these plans happening. So this is why I do a lot of repetition and role playing, because it's more likely, but also having skills and actions in place for that moment. For one of my clients, the window was a big trigger, and having thoughts of jumping out of it. So we taped their safety plan onto their window. So having some things in the moment that are going to help them right then with the things that you've noticed intensify in that moment. We've also noticed a large amount of autistic clients who have past medical trauma from prior hospitalizations, and this can lead to them being more uncomfortable discussing how they truly feel, or a lot of fear that they'll get routine right away if they were to tell you anything. So a common theme is that a lot of these clients have felt like these past hospitalizations were not necessary, and that the clinician acted too fast before hospitalizing, before gathering all the information. And for some of my cases, like that 10-minute discussion of how they might kill themselves, a clinician might just take that at word, but really we need to ask a lot of questions and dive in because we know this is a theme and a pattern. So psychoeducation has been really helpful here with talking to my clients about what is like immediate risk and not for high level of care. And I know it's not a thing you can word literally, so it's been a little hard for clients to understand what gets therapied, what doesn't, what that looks like. It's more immediate, but really exploring that has been helpful. And then also knowing that has helped with some of my clients. For example, I had one for a year who would not answer a PHQ-9, refused to answer any of the safety questions because they've been hospitalized a lot as a teenager, and it was really traumatizing. So a year passed, they're finally answering some of these questions, but know that it might take some time and trust, a lot of trust before they might be honest with you with those questions. And it's important to know your patient. Just one example of this is that there are some phrases that can be scripted, but some that can be meaningful at another time, especially with you all working with teenagers. You might see this a lot. So for example, if the phrase like, "Oh, just kill me now," a teenager might say that very jokingly. And then an autistic teenager might pick that up and say it jokingly too, but it might sound very different if they have a flat affect and they don't say it in a joking tone, and it can sound a lot more serious. So in those moments, asking a lot of questions and knowing your clients to really dive into that. A lot of my adults have learned after they say something like that to say, "I'm just kidding, that was a joke." But as teens, that's something that they didn't know at that time. So it's taken some time for them to learn that and learn that not everyone recognizes those things as jokes. And ask directly, especially when it's uncomfortable. It's important to ask directly, both about suicidality, but also about homicidality. Asking some open-ended questions here might be more successful. I thought of what is going to help keep you safe. Might word and find some better things than yes or no, since that's quite hard to answer. And I could see some people taking it very literally and coming up with a lot of different answers that wouldn't be helpful for you. So maybe what is going to help keep you safe could be helpful. Providing examples if you feel like they're getting stuck of some things that have been helpful in the past. Reviewing their safety plan of, are any of these things going to help keep you safe? Which of these things are going to help keep you safe? And then if that's not successful, also rating scales have been very helpful for me in the past. I've had a client call in a crisis where it felt like they were telling me it was a 10 out of 10 crisis. But when I used a rating scale and asked them, it was really only like a 4 out of 10, and they felt to where it's a 4 out of 10. So rating scales have been quite helpful if you're stuck and not sure the feedback that you're getting. All right, and then we're going to go into some therapy considerations. So just to start with this, I wanted to validate that some feedback we've gotten from a lot of clinicians is that they feel like they're not successful with autistic clients because it's going slower than expected. It's going slower than the other clients they see. They're getting met with some resistance, or some things are happening to where they feel like they need someone who specializes in autism to be successful, when really they've done a lot of good work. And some of this takes longer with autistic clients for multiple reasons. Some of it is from what Cailin has said of maybe it's some chronic suicidality or depression is presenting differently. Some of it is the need for more repetition and practice, and diving into what emotions and needing more psychoeducation and really diving into their emotions first, which other clients might already have that knowledge of. So just wanted to validate that just because it's going slow does not mean you are not being successful or a bad therapist to your autistic clients. And I'll pass it to Cailin for a bit for some of the other adaptations.
Sure. Thanks, Maddie. No, that's such a good point. And it was something that we talked about when we saw some of the questions. Like some were very like, these are sticking points that we see a lot when we talk to therapists, especially when they haven't had a lot of autistic clients or just in general. Like I can even remember that from my grad school training, like other grad students, therapists coming up to me and being like, this is so much harder when they had their first autistic client. And I was like, okay, yeah. It's like, no, it just takes longer. It's all right. So I wanted to start with this picture again from Dr. Iannotti that we've been using with training some community clinicians and therapists, because I really like to illustrate how the sensory environment that you're doing therapy in can really affect therapy for autistic folks. Having a lot of things that can be distracting, UPMC in general, it's like overhead lighting that are really bright and fluorescent. Our place is no different. Using, or in this case, this picture here showing on the left, the bright outside light coming in, requiring folks to stay seated or, making eye contact with you and things like that are really not always going to be very helpful. Versus, this picture on the right that is like the more ideal that we'd like to see. Letting somebody face away from you while they talk is fine. Letting somebody, I've had people pace. I've had therapy sessions, which don't always, it's not ideal or always workable to have somebody walk up and down the hall with you, but sometimes that is honestly hopeful for them. So, just like thinking about all of those things. I think having fidgets available too, particularly, always good. We have those in like all of our testing rooms now for our interviews, just because it's really helpful. So I put in a couple of slides just on some generalizations for autistic folks. This one I stole from our training for school personnel. I think when you're working with somebody autistic, it really helps to think of these general things. How can I say something in the most precise way, the most concrete way, and short? Like, well, I guess it's precise, but just can I ask these questions without a lot of lead up? Can I, use a visual or a list or questionnaires, like Maddie said, to be able to answer these questions? You might have to pause a little bit longer to get responses when you're interviewing or talking to somebody. Wait. It's really hard. I know a lot of therapists hate silence, but it helps sometimes, like, especially as you get to know somebody, like if they need more processing time. Not demanding eye contact, always important. A lot of autistic people say that makes them really uncomfortable, very anxious, might stop them from being able to process things that you're asking them. So a lot of times, I have clients that wouldn't look at me, and maybe at the beginning and the end of the session, and that's okay. Finding ways to reduce verbal discussion in therapy, if you can, could be really helpful. So a lot more behavior versus the cognitive, I think, is helpful. And reducing the amount of explaining. Yeah. Okay. I wanted to add this slide because I felt like it is really helpful. Just general therapy modifications. So there's some CBT has been the most used in autistic folks, and the adaptations that people suggest in different studies and are pretty much similar. They really are pretty similar across a lot of studies and age groups. So if you're working with somebody young, having more parent involvement probably than you're used to might be needed, might be necessary. Like Maddie just mentioned, focusing on emotion recognition, like what is a sign that I am angry or that I am getting dysregulated? You kind of need to do that psychoed probably more than you would with some other clients. Making your sessions the most kind of as routine and structured as you can, like doing the same kind of routine and structure each session if you can hack it, and things like that. Like I said, I usually do more the behavior than the cognitive with clients. And I mean, that's the same. I mean, the fact that you guys all work with youth, I think, teenagers, kids and teenagers, like you have a better idea of that, as well as having a better idea of how to adapt generally, because you're working with different age and functioning and everything level. But the behavioral focus for CBT is really helpful. Like Maddie mentioned, repetition and practice is key, and more psychoed. I think other things that have been shown to be really helpful, so focusing and using somebody's strengths or their talents or their interest, so a lot of autistic people have like an interest or several interests that they're really deep, focused interest that they know a lot about. Using that in therapy maybe is, when you can do it, is really helpful. And again, using as much visual thing that you can do and role playing that you can do so that it's really can be helpful, I think, for a lot of autistic folks. It doesn't have to be cutesy either when you're working with teenagers, but just having written things, even like, working with teenagers and young adults, we've just had like a whiteboard or a sheet of paper where we just put out like, here's the things that we're going to cover today in this order. It can be helpful. So it doesn't have to be cute or, make somebody, a teenager, angry that it's too like little kid. So this is an example from EASE, which is a mindfulness and CBT kind of therapy that I helped co-create. This is when we adapted it further for folks with higher support needs and folks with intellectual co-occurring like intellectual disability. But it's just a way to like conceptualize this to therapists using the manual. So like these spectrums kind of like all shift depending on the client. And it changes up kind of like different pieces of the manual that you use, or the number of sessions needed so that you can get the right amount of like repetition. So, again, having a support person or the caregiver involvement. Typically, if I can, I'm going to use the support person more in therapy for someone with higher support, and less so maybe, just as like a coach or somebody to help us figure out how to generalize those skills outside of session, like bring them in at the end and talk about, like, here's the homework for the week and how are we going to get it done. For somebody that doesn't have as much need. Cognitive change, like I said, folks with intellectual disability, we don't necessarily focus as much on, using some of those like cognitive strategies you see in CBT, like reappraisal, or we use diffusion or distancing. So things like that. Pacing, again, more repetition, especially the higher the support need is. And it might be also just a slower pace overall. Like instead of covering 3 new things in therapy today, I'm going to focus on 1, just to really focus in on it and practice it and think about it in different ways, and see what sticks. And then scripts. So we learned that, we kind of use like similar like helper thoughts, and we'll usually take, individualize them to the person, but use those a lot during therapy, like as a coping skill for somebody that has higher support needs and maybe isn't as verbal. So, there's a thought that they can use. I'm going to let Maddie talk about this.
All right.
I know she's got experience.
Yes. I've run multiple DBT groups for autism, but also for intellectual disabilities. So I wanted to specifically focus on this question, but if you have any other questions about modifying DBT, I'll be happy to help with any of those questions too. So this question was, in a group setting, how is it best to respond about invalidating their experience when multiple group members are feeling stuck or rigid? For example, being unable to challenge a thought that feels true as factual, or struggling with dialectics or balancing opposites. So first thing with the question of how to respond about invalidating, I find it helpful to validate first before problem solving. It could be helpful to focus on what you both can agree on, which often is the feeling. So maybe they said like, this is the worst moment of my life. I'm furious, right? You can validate that anger before diving into, is this really the worst moment of your life? So validating first their feelings before diving into that. And then, DBT has a lot of abstract statements and metaphors that can be quite challenging. So especially for some of these, we might need to really break it down and give examples, relate back to things. So for example, just the two opposite things can both be true is a pretty abstract statement that might take a lot of examples, repetitions, and visuals. We can also use logic, playing on the strengths of autistic people, to help with examples. So I thought of like day becomes night, but both are part of the same cycles. Using logic in any ways that help to illustrate this fact, because it's a really hard thing to grasp. Role playing and using visualizations, Venn diagrams might be helpful for the two opposites. Charts could also be helpful, and then lots of repetition. So on the next slide, I have an example of using an interest to modify. So I used Harry Potter, a very common interest. So what the two opposites can be true. Snape was brave, but he was also mean. I have a Venn diagram over here of the opposites. So there were good traits. He was brave, loyal, intelligent, but he was also rude and secretive, and showing that both of these could be true. For role playing based on interest, we could role play the friendship conflict. Ron felt left out when Harry was hanging out with Hermione, but he still valued his friendship. Looking at both of these, the thoughts we have, how might you play that in a real friendship? What would that look like? And then after using these examples, relate it back to their life. So Dobby, he wanted to protect Harry, but he also sometimes made things worse for Harry. So can you think of a time where or what would you say to Dobby to help them balance their feelings? Or can you think of back a time where you felt two opposite emotions like Harry did when he felt guilty about Cedric's death, but also was proud to stand up to Voldemort? Really using some examples and then tying it back into their life could be quite helpful. And also, it doesn't have to take a lot of effort. I know this sounds like it does, but an excellent resource is honestly ChatGPT. And if you don't know like someone's interest, like let's say you don't know a lot about Pokemon and that's their interest, it can give you a good intro. You can say, please tell me some ideas where there are opposites in Pokemon, and it can come up with a good list. So it might sound like a lot of work right now, but honestly, it doesn't have to, especially if you use a resource like that, or you can even ask them to explain their interests more and then getting some examples from that. Those are some that's been helpful when I don't really know their interest, or if there's something that's really, I can't think of, like, I work a lot with OCD and with exposures, I couldn't think of examples of how, with someone who was thinking of soap as poison and I needed some good exposures, and ChatGPT came up with an excellent list of exposures for that. So don't be afraid to try it. I found it very helpful for just coming up with some ideas. All right, next slide, Caitlin. And then I know Caitlin added this at the end, but I also want to talk about the neurodivergent friendly workbook skill for DBT skills, specifically show you a page from it because I wanted to show you some of the things I'm talking about. For Wise Mind, it's a simple visual and it has some examples and it's very simplistic. It has the visual there and it's a resource that is free to share. So that's something that's really nice about Sunny in this resource is that they've made it free to distribute. So this is a really cool resource to use. All right. And then there are some questions based on group. So you might need to modify group roles if you're seeing a lot of group situations come up. Have another clinician pull patients aside if needed. We typically do our group of 2 people because we frequently have to pull someone aside if they're getting really upset or something's going on, and while the other person manages the other group if that's possible for STAR or the other clinic. And then I've had to have some repeat phrases for some common tricky areas. So for peers, the social skills group, there's a lot of statements about what works best, and I get a lot of pushback about, okay, but this wouldn't work for this situation, or what about this situation, this wouldn't work. So I've said this phrase so many times of this is a rule that helps the majority of the time, but there are exceptions. We're going to focus on the majority of the time right now. So you might need some phrases like that that are your go-tos for some common areas where you get a lot of pushback. And then having coping skills accessible, we always have fidgets on the table, multiple different ones. We sometimes have to change the lighting, change things about the room, shift things around, being flexible ourselves, including breaks when they're needed. And then it's a good chance to also practice accommodations. So, for example, some common school accommodations for autism is maybe receiving like slides ahead of time so they can look over it, printing it off, having it there, having extra visuals ready, whatever might be helpful or what they might receive at school could be helpful to tie into there too. All right, and then there was a question on rigid thinking. So the question was concrete thinking / rigidity in individual sessions. What is the best way to approach this? We would like specific skills related to working with this. So a specific skill I could think of was scales have been a little helpful for me here. So there is, this was, if you type in Google, like reducing your all or nothing thinking, you can find a worksheet on this. But here is an example scale to the left. If someone said, I hate my boss, she's the worst person in the world, I would then say, first, right, work on validating it. I hear that she's really upsetting you. What's going on? Exploring that. And then I might write a scale, best person in the world, worst person in the world. And I'd probably start on the opposite. I'd be like, okay, so who's the best person in the world? Have them come up with whatever that is. And then who is the absolute worst you can think of? The scale is Hitler. And then be like, okay, so on this scale, like, where is your boss, you think? And this person still put their boss pretty low, but still helping challenge some of that with a scale has been helpful. And then weighing the value of what you are really trying to challenge. Just like with OCD therapy, we don't challenge every thought. We want to mainly get behind the anxiety behind it rather than actually challenging the thought. So is it really worth it? And is it helpful to challenge this and seeing what you're actually trying to get to? Because if you're trying to get to the anxiety, maybe it's best to just ignore that and focus on the anxiety behind that. I have a teen who, whenever they get angry, they like to blame like Russia or like some random things that doesn't have to be involved with their problem. And often I ignore it. I don't challenge it and focus on their actual anxiety that's going on or the actual anger that's going on. And that's been quite helpful because if I do try to argue with that or push that or challenge that, it's not going to be helpful for them. And it's what they want. They want to be focused on whatever that is. And that's not the main point that they're there for. And then we need to be flexible ourselves. So there's not always going to be a specific skill for working on it. Cailin and I were talking about the modalities we use, and I found it funny that we use basically all of them adapted because there's nothing that specifically works for autistic people. So we have to adapt everything we do, and that's okay. And we need to be flexible with that ourselves to know that nothing other than ease was made specifically for autistic people, and it's going to have to be adapted and changed. And DBT likes to be followed pretty strictly, but that's just not going to work if we follow it to the T with autistic people. And then we might need to agree to disagree at the end. Same with weighing the value of what we're really trying to challenge. It might come down to it's not the main point we need to focus on. I would just need to agree to disagree on whatever it is. Okay, and then a life worth living. This question was on having a hard time about what keeps people going or keeps them living and building a life worth living. So I'm wondering here some of the issues with the wording, because a life worth living could be a hard question to answer and maybe too abstract. And then also what keeps you going / alive. I know so many of my clients would answer that very literally. They'd be like, water keeps me alive, breathing keeps me alive. And you would not get what you're actually asking. So making sure we ask one question at a time and maybe changing it up if we're not getting the answer we want, since it might be taken literally, like what makes you want to live, what makes you happy, exploring in that area. People may respond with unexpected answers. Jacob, the other presenter, had an excellent example of a Wikipedia page kept someone alive. And that's their truth. The Wikipedia page is what made them so happy that it kept them alive. And so we have to be okay with that. And also it's helpful to know if that Wikipedia page ever gets shut down or something, like that's their main thing that's keeping them going. Maybe giving ideas or choices, same thing we've talked about before. Having pictures or a common list of what keeps other people alive may be helpful to look at, but just having some options, because I know at that moment people might feel really frozen with that question. It can be quite hard. So having any examples or anything on hand that could be helpful would be good. And then we want to acknowledge that it may be hard for autistic people who've lost their main interest to find joy in things, because often the answer of what keeps people alive or happiest is their interest. So if they're really depressed and have lost this interest, it may be really, really difficult for them to find something. And so we want to focus on the very, very tiny things that are keeping them a little bit happy right now, or keeping them safe right now, because there may be close to nothing at that time if they're having that hard of a time. And so, yeah, that was our thoughts on the question. And then we have our resources.
Okay, I promise we're almost done because we talked really long. So just some general resources, and then we'll leave the rest of the time we wanted to answer any questions or discussion. So there are some really cool toolkits from AAS. And that's already a good question. Cool. Sorry, I get distracted easily by chats. But you're okay. Keep putting stuff in. There was an autism focused special interest group in AAS. I can't find that stuff on their website anymore. So I put in this other website because it's one of the autistic partners who worked on that, and she will never shut down her website. So at least I don't think she would. So there's information on what it's like to call 998 that's directly for the autism community so that they know what to expect. Because Maddie's really good example. Like that is sometimes half of the battle is like, I don't know what will happen if I do this. So knowing what would happen would be helpful. There's some information for it was designed for crisis care workers and other professionals to identify autistic people if they're calling in to the hotlines. There's a longer thing that's called warning signs of suicide for the autism community, and that has some really good case examples if you ever are interested in those things, of what it might look like or what things might look a little bit different for somebody who's at risk. And then they did an autism focused version of that. There's some other versions of safety plans I put in here. Some things from ACERT, which is a state organization or part of the state government here, that's autism focused. That safety plan, that big long honking one from the UK, we put in here. The website of Lisa Morgan, who's that autism suicide consultant with lived experience, she's first of all great. She trained our whole research group, but that's her main website. But the resources, like I said, for AAS and other things are there. And there is a paper again by Jessica Schwartzman, a different one, that was about using safety planning resources for autistic youth. And there is this table at the bottom about how to adapt safety plans that I thought might be helpful. So I tried to put a link in there. General resources, CAD and React that you guys have here. And the healthcare toolkit isn't really specific to autism, but just because we were talking about, medical-based trauma and hospitalization causing a lot of trauma for our clients, this is something that folks can use just generally going to health appointments, which I found very helpful. So you've seen some of these already. I think use pretty much all of these. Maddie already talked about the neurodivergent workbook, friendly workbook for DBT. There's also this one that's DBT for intellectual disability. This one by Julie Brown that I have, and I know like past interns have used it for clients, and it seems to have worked pretty well. And then there is a general like CBT for autistic adults book that I recommend to people when they do CBT. And I mean that's pretty similar across group. I think age, you could probably, knowing working with youth like kids and teens, you know how to kind of like adapt those things over. And then these two papers I put in here because they both have some good examples. So for DBT specifically. So this first one by Keenan et al. Dr. Keenan has actually done CBT and is autistic. And he, similar to Maddie's really cool examples, had like DBT examples for Pokemon, and I think Dungeons and Dragons are the two examples he used to like kind of like do differential things that you could use for DBT. And there's this other main paper that talks a little bit about other adaptations that they did during a pilot study. There's a growing literature base using DBT in autistic folks and showing that it works. So, and I know you guys are always good at using DBT with autistic folks. So, like you're not turning people away, which is our worst case scenario that we hear from folks in other areas of the country. So, okay. All right. I'm going to stop talking. Thank you guys so much.